So good morning again, everyone, and welcome to our webinar today, Sleep Series 101, Let's Sleep for a Healthy Development. This is the first in our two-part series with our wonderful friends at the National Institute of Mental Health. With us this morning, we have Dr. Melangel Concepcion Zayas, who is a child, adolescent, and adult psychiatrist at the National Institute of Mental Health, and is working with, I know, Dr. Shu Buckley on this incredible research around sleep. And so welcome to Dr. Concepcion Zayas. We're so happy that you're with us this morning.
Good morning, Mary Beth, and thank you for having us here and giving us the opportunity to speak to your audience, which is really important for us. Welcome, everyone. Thank you for the introduction again. And today, as Mary Beth said, we're going to be talking about sleeping for a healthy development. And as a physician, and as a public health practitioner, I will say that sleep should be part of any health assessment, and it's a daily conversation with the families that I care for. As Mary Beth shared, I have the immense privilege of being part of the Sleep and Neurodevelopment Consult Service at the National Institute of Mental Health under the direction of Dr. Ashura Buckley, who is a child neurologist and principal investigator. She's a visionary who, since 2016, has been leading the science of neurodevelopment and sleep nationally, and who will be giving the second part to this series. I'm part of a team, so just one of many. I have some disclosures and disclaimers. I have no conflicts of interest to report. All opinions presented this morning are my own. Support for this work is from the National Institutes of Mental Health Intramural Research Program, so thank you. And this presentation should not be considered medical advice for any specific patient. I am not endorsing any specific intervention that I will be perhaps presenting here. And I always encourage to speak with healthcare providers about the benefits and risks of any treatment. And if you have any questions around medications, you can visit the U.S. Food and Drug Administration website, and you have the address there. These objectives, I believe, were shared with you, and we will navigate the first three of them today, and the other three will be navigated in 2 weeks by Dr. Buckley, so we hope that everybody stays tuned. So let's start. Let's go to our objective number 1. We are going to define sleep and acknowledge the importance of sleep for children's healthy development. So we spend a third of our lives sleeping or attempting to do so. No wonder why, in Greek mythology, the god of sleep, Hypnos, influences all people, even the gods, for many of their lives. The myth says that each night, Hypnos traveled around the world with his sons, the gods of dreams, who brought both peaceful dreams and nightmares. Nightmares have been depicted among multiple cultures through art. And here, bear with me, I'm all about self-reflection. I want you, audience, to pause here and make a self-reflection that will make sense at the end of the talk. And I want you to think about what dreams and sleep means for you personally, and what does it mean within your family and within your culture. Sleep and dreams are experienced throughout time, different cultures, religion, art, literature, and Disney. Yeah, you heard well. Sleep disorders are depicted with movies with great details in some of Disney's movies' characters that were developed as early as the 1930s. Even before sleep became a formal science in the 1970s. We spend a third of our lives sleeping or attempting to do so. Sleep is considered a biological need indispensable for the holistic development of children. But why? Before we answer this why question, let's briefly define sleep. What is sleep? Sleep is a reversible behavioral state in which there is disengagement and unresponsiveness to the environment. Has been defined also as a complex amalgam of brain activity and physiologic processes. It has different stages that cycle rhythmically, illustrated to the left of the slide in your screens. And during unusual circumstances, other behaviors can occur during sleep. I want you to focus briefly. Let's bring the attention to the left side of your screen. And this is how we basically exist in life, in the awake on the left and on the sleep mode, which has like two overall big phases, 4 stages in total. And this is the intrinsic rhythm when we sleep as well. And this rhythm, it's called the ultradian rhythm, which means shorter than a day, but longer than an hour. And in human sleep, it is about a 90-minute cycle. We usually go through multiple cycles at night, cycling between the non-REM, REM, brief awakening, non-REM, REM, in about 90 minutes. So this is just to illustrate the stages of sleep. And at the bottom center of this slide, there is someone sleeping. And if you can see, it's a little bit small, but they are connected to cables. And this is just to let you know that we have something called a polysomnography, also known as the sleep study. And this is the device that helps us monitor the sleep stages and cycles. And it allows us to identify if or when sleep patterns are disrupted and why. And the standard process of falling asleep begins with a sleep stage called non-rapid eye movement, NREM. And this is characterized by low brain activity. Here, the body movement is preserved. There's regular respiratory and cardiovascular parameters like the heart, and we continue to breathe normally. And around 6 months, the non-REM further divides into different stages. At the left upper corner, you can see stage number 1 and 1, which is the transition period from wakefulness to sleep. And it should last normally around 5 to 10 minutes. Then we go to N2, the body temperature drops, and this, we start to relax. In the sleep study, there are some things that we call sleep spindles, and the study starts to capture that, and this stage lasts approximately 20 minutes. Then we go to N3, and this time your muscles are relaxed, and this is when the deepest sleep occurs. This stage is really important to the restorative functions of sleep that we will discuss ahead. After these 3 non-REM stages, the brain activity picks up again, and rapid eye movement ensues. And this is what you heard about REM. Probably know about rapid eye movement. Is a time of a lot of activity in the brain. The brain is consuming a lot of energy. Our body starts we lose control of our muscles and skeletal tone, except for those of breathing, and rapid eye movement ensues. This is when dreaming occurs. It occurs during REM sleep. So we have briefly defined what is sleep and the cycles of sleep. Now let's go to the why is sleep important. The true purpose of sleep needs to be better understood. However, experimental data support various essential functions of sleep, including energy conservation, optimal function of the organism through restoration, repair, and healing of the body. Sleep is important for promoting growth and development of the central nervous system, and it helps with brain plasticity. In addition, there has been an explosion of discoveries showing that sleep participates in memory processing and consolidation in everyone. Yes, that's right. It's important for you as well, which has important implications for cognition and learning. Sleep is considered a biological need essential for health and indispensable for life. Unfortunately, as a society, we are not getting enough sleep. Sleep insufficiency exists when sleep is not enough to support adequate alertness, performance, and health, either because of reduced total sleep time, the decreased quantity of the sleep, or fragmentation of sleep by brief arousals, or the quality is affected. Insufficient sleep is considered a public health problem, and it has the potential to affect multiple realms of health, including problems with attention, behavior, learning problems. Sleep insufficiency increases the risk for chronic illnesses such as hypertension, diabetes, and it can cause long-lasting damage to the brain. Insufficient sleep is the leading cause of daytime sleepiness in children and teenagers. There's actually a survey in the United States called the Youth Risk Behavior Survey that found that 7 out of 10 adolescents of students reported an average of less than 8 hours of sleep on school nights. Sleep insufficiency in teenagers is associated with increased risk of self-harm, suicidal thoughts, and suicide attempts. So here we have what I will say a significant thing to consider. Okay, with that, and I hope I was really clear on the importance of sleep, why we need to sleep for our health. We're going to transition to objective number 2. And if you have any questions of objective number 1, write them down. I will address them at the end of the presentation, okay? So the objective number 2, we will provide an overview of the sleep and wake cycle. And it has been well established that all living beings are guided by circadian rhythms, defined as estimates 24-hour periods, which are synchronized to the Earth's daily rotation by a mechanism that is called entrainment. And our human circadian clock is in a place called the suprachiasmatic nuclei in the hypothalamus, and its function relies on important signals that represent the regular changes in the environment. Light, natural light, sunlight, is the most crucial signal. Circadian clocks regulate and modulate functions at all levels, from the smallest cells to the most complex processes on how we actually process information and think. Research has shown individual differences in how these circadian clocks work within the day. This has allowed to the identification of what is called chronotypes. And a chronotype is the natural inclination of the body to sleep at a certain time. And we can hear colloquially as people being early birds versus night owls. This is what we're talking about. Chronotypes are known to have a genetic basis. So night owls run in families, early birds run in families, but they also depend on the exposure of light that we receive throughout the day and other factors such as age and sex. Also, the lifestyles of modern society, it's important to mention this because it poses many challenges to the circadian functions in humans. And this is in the context of factors such as lack of signal strength. We are not getting enough exposure to sunlight by working predominantly inside. The exposure to artificial light at night. There's a lot of people that need to travel for work, and there's associated jet lag that becomes a challenge to our clocks, and some working schedules that we have, and this might be familiar to the audience who might be working at night. And for our children and adolescents in the school setting, the school schedules and the use of electronics are one of the biggest challenges for those circadian clocks. Beyond these evolutionary circadian rhythms just mentioned, how sleep and wake are generated and maintained is more of a balance between two systems or two processes that we call the two-process model of sleep regulation. And one is the process C, which is circadian process, which we just started discussing, and then process S. As the day goes, you see to the right of, there's a small chart there, starting at 9 a.m., they start, those systems or processes counterbalance. So let's go more in depth to the circadian regulation or the process C. We already had established that our human circadian clocks are controlled by the suprachiasmatic nuclei. And within this sleep-wake regulation, the nuclei, this place is primarily responsible for melatonin production. Melatonin is a hormone whose production is regulated by light. What this means is, with the decrease in light exposure in the evenings, there is an increase in melatonin production, and vice versa. When we are sleeping, we wake up, there is an decrease in melatonin production. Developmentally, melatonin production tends to drop during puberty. So as we approach adolescence, the production of melatonin is much lower, and in older people, it drops even further. This process C is also associated with body temperature regulation through a chemical messenger called serotonin. And it is known that when we fall asleep, the sleep onset and a reduction in core body temperature occur together. If you remember the stages, we had the N1 and the N2. It's between like after 10 minutes that we fall asleep, our body's temperature are dropped. Process C is also important for the production of critical hormones that are released during the sleep cycle. And this is, pay attention here. These hormones include growth hormone, which is essential for growth and development of young children. And the production happens early at night when the kids are in the deep stage. And it's not only important for children, but throughout life. This hormone is vital for muscle development, for our bone density, for the metabolism of all the fats and sugars, and for the healing of the tissues. There's another important hormone called cortisol, or the stress hormone, which is released during sleep. Its production increases overnight to promote alertness when it is time to wake up. Cortisol level peaks around 6 in the morning and dips to their lowest around bedtime. High cortisol levels have been associated with sleep disorders. So if we're stressed at night and we keep those cortisols level high because of stress, there has been like an association with some sleep disorders. So we discussed process C, or the circadian process controlled by the central nervous system. Now let's focus briefly on the homeostatic process, or process S. This is a function of sleep deprivation. So when we wake up, sleep pressure starts to build, and the periods of prolonged wakefulness continue to increase the sleep pressure. Sleep pressure peaks just before bedtime. So through the day, we're using energy, which we call ATP, and that starts producing something called adenosine as a byproduct. And that accumulation actually in high concentrations will low down the arousal, and it causes sleepiness. When we go to sleep, the sleep pressure starts to dissipate throughout the night. So in the morning, sleep pressure is at the lowest. To maintain these processes at the molecular level, multiple neurotransmitters or chemical messengers are at interplay. And this is an oversimplistic slide of them, and they are beyond this lecture, but they are essential to mention as we have already touched on some, and we'll discuss some others throughout this conference. We saw melatonin, serotonin, and adenosine, if you can identify them. Okay, so we have illustrated two things already, which is the two-way process of sleep-wake regulation. We illustrated the neurotransmitters involved in the sleep-wake cycle. And now let's add some factors beyond that pure biochemistry that makes sleep a bio from biology, psycho, social process. When we talk about sleep, we need to think about the context. We need to think big about the context of society and culture. We need to think about the environments for sleep. We need to think about sleep practices at the family and at the individual level, behaviors around sleep. We need to think about health, about development, among other things. And this context, it's extremely important in health. It is so important that there has been an emergence in the use of a socio-ecological model. And if we have educators here, they might be really familiar with this when addressing the sleep, as it can provide clarity about how different social determinants impact sleep health. I mean, when we look at this, sleep it's kind of a big deal. And beyond the individual focus, there is a need to include the cultural and public policies domains that shape health outcomes when we're talking about sleep. With these complexities in mind and the challenges of modern society, what can we do, or what can you do to help your internal clocks and help the internal clocks of those around us? This is like starting to build this sense of a community for sleep awareness in the circadian C or process circadian process or process C, as it relates to the melatonin production. It is important that we maintain regular sleep schedules, that we promote the exposure to blue light early in the morning. So when that alarm rings, let's open all those windows in the house. Let's get exposure to the lights. If you live in a basement or you live in a place with limited sunlight, which happens, let's try to take those kids outside. Let's go to get some exposure to natural light. If there's no possibility, sometimes there are some lights that can be used, and that they help our brain keep into that balance. Okay, we need to avoid, and this is the most difficult one, right? If you have kids and adolescents, how do we avoid exposure to blue light in the evening? This is the one that, as a clinician, it's one of the most difficult to address, but they get the message. So it's a matter of making them understand the why. And here the questions around melatonin usually arise. But Dr. C, what about melatonin? Everyone is taking melatonin. Is it safe? Should we take it? My child is taking it. And the medical answer to this question is if you're having problems with your sleep, we recommend talking to your doctor. And I will answer some of those questions that you have to the best of my knowledge at the end of this lecture with a slide, okay? In terms of the process C as well, it is important for body temperature regulation. We mentioned that. So the recommendation is trying to sleep in a cool room. If you exercise at night, or if you work with your body, to allow at least 2 hours between exercise at bedtime. We also recommend to take a warm bath before bed for relaxation. And this is something that when I discuss this recommendation in the outpatient setting with the families, in the summer I hear, but doctor, we cannot do this. We don't have air conditioner. Sometimes I've heard there might be no warm water by the time that my child needs to shower. And these are things that we suggest, right? And they might not work for every family. But when you are thinking about it, and when you're bringing this to your physician, bring all these things to the attention of to our attention. And something that I always encourage, regardless of the sleep environment, is when we have sleep conditions that are uncertain because of any reasons, the recommendation is to try to make predictable routines or special rituals with meanings for the kid that can provide a sense of certainty and security. Okay. In terms of what we can do to help this process for the production of other critical hormones, we say sleep long enough, and how much is long enough is based on consensus recommendations to promote optimal health that I will share shortly. And we actually encourage sleep in environments promoting good sleep quality. What we can do to maintain the homeostasis or that balance for sleep pressure, especially for those adolescents whose pressure builds at a different pace, we say try to avoid caffeine, as it inhibits adenosine and it gives you a subjective sense of being awake, but you aren't. We say avoid stimulants, and if stimulants are needed for medical reasons, the bottom line here is if a child is started in anything and you see a change in their sleep patterns, tell your physician, okay? There are always options. For increasing, for the fact that we build the sleep pressure after prolonged wakefulness, we tell the parents, let's try to avoid long naps in the evening, okay? Regularly sleeping fewer than the recommended hours is associated with adverse health outcomes and long-lasting impact. We have discussed this already. But how long we should be sleeping to promote optimal health? The experts recommend in children between 3 and 5 years, a range of 10 to 13 hours of sleep, including naps. For children 6 to 12 years, they should be getting 9 to 12 hours of sleep. For teenagers, 13 to 18 years of age, they should be sleeping 8 to 10 hours. And for adults, 7 or more hours per night regularly. It is what has been discussed to promote optimal health. And I want to take another 30 seconds for self-reflection here. Are you and your family getting sufficient time to sleep? And what about the sleep quality, the quality of your sleep? Okay. With that reflection, I'm going to transition to our third and last objective, which is to identify, we're going to try to identify some common sleep concerns and sleep disorders in children and adolescents and how to approach them. And this is a presentation that might sound familiar to the audience, and it is common in the school and in the medical settings. So there's a 5-year-old with history of disruptive behaviors, which are difficult behaviors, actually. That's how they are called. And they are present as inability to follow directions, inability to sit still. The child is observed energetic as the day progresses, and there is some reactive aggression towards the peers. The school has discussed that the child has some academic struggles, and mother has extreme fears that he will be kicked out of school. Oh, they're going to kick him out of school. They're going to kick the child out of school. The mother of patient is concerned about the sleep of the patient, and there is trouble falling asleep. The child is presenting with intermittent awakening, so he wakes, the child wakes up in the middle of the night. They often move and makes noises when sleeping, and the child looks tired in the morning. Patient is sleeping an estimate of 6.5 hours per night. So again, I want you to take a picture of that. Really common presentation in the school and academic setting. And before we go to a more in-depth discussion around this specific spoiler alert here, sleep disorder, and more in-depth discussion of our of this case, let's look at common sleep concerns experienced by children depending on their developmental stage. So between the 3 and 5 years of age, children achieve independence, they start to move around, and this might bring some limit testing behaviors at the time of sleep. At the language and cognitive domains, parents hear well, if your child is 3 to 5 years of age, there is a rapid acquisition of skills. They can comprehend cause and effect. They start to understand the symbolic meaning of objects. There's a lot of fantasy, there's a lot of curiosity, there's explosion of expressive language development, and that does not come without concerns around sleep time. That can bring this development can bring some bedtime resistance. It can bring some heightening of nighttime fears. At the socio-emotional level as well, at this age, they are starting to self-regulate, and there's a drive for autonomy and independence. And this can lead to some separation anxiety as a concern. Oh, sorry for that here. So what are the common sleep concerns between ages 3 and 5? Again, limit testing behaviors and bedtime resistance affects 10 to 30% of toddlers and preschoolers, and it is often associated with poor parental limit setting. There's also night awakenings due to inappropriate sleep associations, and this is when children need parents to be around, or they need to be rocked or breastfed when they fall asleep. They can develop these associations, and because we all have like brief arousals, for them at this age, it is difficult to fall back to sleep after those awakenings, because they need the same conditions that they use when they are falling asleep for the first time at the beginning of the night. We have the nighttime fears, and there's something really important at this age, which is called the second wind or the forbidden zone. And this refers to the fact that our alerting system starts to peak and work its hardest towards the end of the day. There's a specific time of the day when all our senses are completely aroused and increased. And it's this peak that is responsible for your child's high energy at the end of the day. So, oh my God, by the end of the day, this child looks like, I don't know, a lot of energy. It's a ball of energy. So it presents like a second wind, like supposed to fall asleep and now super alertness. And if this time coincides with the time that your child is going to bed, that can be a limitation, okay? On the positive side, at this age, there is an increase of interest in literacy. So this is a good time for those bed routines to include reading to your child, read. And they also start to respond to positive reinforcement. So having behavioral plans and consistency and structure is also really beneficial. These are some developmental considerations and common sleep concerns for age 6 and 12 years of 6 and 12 years of age. And at this time, they're approaching puberty, which is approaching like that adolescence time. And they already have developed some circadian preference. They are able to understand the real life dangers. There is increasing independence, and they start to rely on peer relationships and social situations. This is a time where social anxiety can actually ensue. There's separation anxiety. There is a lot of nighttime worrying associated to academic achievement that starts happening, and that can get in the way of the child falling asleep. And then on the social levels, they are all these social expectations of extracurricular activities that can be in conflict with parent work schedules, and we add to that media use and electronic, and those are common concerns. So our 6 to 12 years of age are getting irregular sleep-wake schedules, they are going later to bed, and they are having insufficient sleep. with the result of having decreased total sleep time. And sometimes they still require the parental presence at bedtime if there are a lot of anxieties around that. They need a lot of reassurance. In terms of the adolescents, when children reach puberty, when they are becoming adolescents, sleep needs remain unchanged from the previous age group. There is association at the hormonal level. If we remember the melatonin, that there is an associated shift to our shift phase delay on the production of the hormones. There is suggested increased sensitivity to the light, and because of melatonin suppression, there's also lower accumulation of the sleep drive. There are discrepancies at this age between wake times in school nights versus the weekends, and these can lead to our adolescents to being like jet lag-like. Also at the social level, there are discrepancies between wake times in school, and a big one here is the access to social media that I cannot emphasize much more. We need to have like some restriction around this, and when we have the discussion, I usually tell the kids, hey, don't blame mom and dad, this is a medical recommendation, okay? So in terms of the common sleep concerns in adolescents, there's a lot of sleep-wake variability from weekday to weekend. We have adolescents with chronic partial sleep and sleep restriction. They are falling asleep throughout the day with daytime sleepiness. They start consuming caffeine and other substances, such as Monster drinks, Red Bulls. Please be mindful that those will affect the sleep patterns of the child. So if they have to go to sports in the afternoon, oh mom, please let's get this Monster drink, or dad, let's get this Monster drink. Let's think about this. Let's talk about this, okay? Why? Because when they are sleep deprived, there is also an increased risk of behaviors that will place them in unsafe conditions. If they are driving, they can fall asleep while driving, and those are safety considerations. Also important to mark here that this developmental period marks the onset of mental health disorders for many individuals. So in life, I hope that I have been able to express the importance of sleep so far, and we should be definitely talking more about the importance of sleep. And when it comes to the clinic, we must do our best to systematically address the concerns. These are screening questions developed by a pediatrician, last name Owens, and I appreciate having exposure to these questions in my training because they prompt really good conversations with my patients and their families around sleep. You can take a snapshot of these questions because you can also have conversation with your children around sleep. After the systematic approach, we are often looking for red flags in the clinic, which are clinical indicators of possible serious underlying conditions. Red flags are basically signs and symptoms found in the patient's history and clinical examination that needs follow-up. So parents, educators, clinicians, if a child is having the following, these are things that warrant further follow-up. Okay, if they have difficulty initiating or maintaining sleep, if there's persistent snoring, some snoring is normal, but there's a snoring accompanied with mouth breathing and the consistency that warrants further approach if it happens more than 3 times per week. The excessive daytime sleepiness, and this is usually manifested by kids who need consistent naps, kids who are dozing up in school or in car rides or while watching TV. And the people say, oh no, he fell asleep because he's not interested in that show. If they fall asleep when they're watching TV, that's a red flag, okay? There's also irritability and changes in mood. So first thing, if there's a big change, is my child sleeping well? What happens if you don't sleep well in the morning? Do you feel well? There's a change, right? And this is the biggest point that I want to make, that most common presentation in children, I will say, associated to insufficient sleep and sleep problems are behavioral changes in the child, attentional problems, and usually academic problems. This is just to illustrate at a sleep assessment what we do, the really relevant aspects of the clinical history. And when we go in depth into our history, we know studies have identified factors that increase the risk for sleep problems. Some of these are children who are born before week 38, neurodevelopmental conditions such as developmental delays, autism spectrum disorder, Down syndrome, and attention deficit hyperactivity disorder, or ADHD. There are some genetic conditions associated as well. The mental health disorders such as anxiety, depression, and post-traumatic stress, among others. And another big one, which is our another vital signs that we use, is pain. When we are assessing sleep as well, we look for medications with potential impact on sleep. And here we have a list of some possible offenders. There's a warning in this slide: do not start or stop any medication without consulting with your doctor. The bottom line of this slide is, if your child was started in a medication and there was a change in their behavior or in the way they're able to fall asleep, tell your doctor about it, okay? And then there are some off-label medications that we use in children and adolescents that have sleep problems. This is a list. Again, this slide does not constitute medical advice, and the medications here they have different evidence level, and they all warrant medical consultation for being prescribed. There are some predictors of child sleep problems in early childhood at the individual and at the parental level. So we know that difficult temperament, previous sleep problems with psychopathology, mental health psychopathology, and electronics use with bedtime TV viewing and electronics in the bedroom actually correlates or are predictors of child sleep problems in early childhood. At the family level, needing parents to be present at bedtime, having lack of structure and consequences for the sleep routines has been associated to sleep problems. And there's a big discussion right now on how socioeconomic status can actually incide on the problems with the sleep. Good news about this is that bedtime routines are found to be protective. So we can do something about some of the sleep problems we have in childhood. Just to illustrate that there are diagnostic tools besides the clinical history and physical examination that are used to assess sleep concerns. And then let's go to the sleep disorders in children and adolescents. Sleep disorders are reported in 10% to 25% of typically developing children, and as many as 40% to 100% of children with neurodevelopmental disorders and neurologic conditions. And these sleep problems for this specific group population may further contribute to disease burden and symptomatology. This slide illustrates how sleep disorders are classified according to the 3rd edition of the International Classification of Disease. There are more than 80 sleep disorders distributed among 7 categories. If you count, there are 6 big categories here. And there's another one, the 7th one, it's called Others. And I have placed here the most common ones affecting childhood. And we start with the insomnia being the most common. Then we go to something called parasomnia. And I'm going to go in a little bit of details with some of them, with a prevalence of around 13%. Then we go to the circadian rhythm sleep disorder. This one, as you're going to see, the specific one, it happens more in adolescents, and it's delayed sleep-wake phase disorder. We have the obstructive sleep apnea syndrome under the childhood obstructive sleep disorder breathing with a prevalence of 1 to 3%. There are some sleep-related movement disorders, and there's also hyperinsomnia of central origin, with narcolepsy being the most common in childhood. So let's start with insomnia. Insomnia is the most common sleep disorder. It's reported in 10% to 30% of children, and it can stem from behavioral, medical, or psychiatric causes. It is defined as difficulty initiating or maintaining sleep or early morning awakening, resulting in a complaint of sleeplessness and decreased daytime functioning. There's a little bit of a difference on how it shows in childhood. And as we mentioned already, if we remember those developmental considerations, in the younger kids, it's a lot of bedtime resistance and night-wake associations. And in adolescents, it's more like the psychophysiological component of it, which is all the worries and all the expectations. Some important considerations is that in adolescents, there is a higher prevalence in females that has been observed. And this insomnia, this is important learning point here, it increases the risk for substance use and suicide risk. So we need to make sure that our adolescents are sleeping long enough and with good quality. We diagnose insomnia with a clinical assessment, and the evidence-based intervention is a lot of education, and we can provide some extinction techniques. And then there's something called cognitive behavioral therapy for sleep, which is actually the evidence-based recommendation for insomnia in children. For selective cases, medications for sleep can be recommended, but for this medical assessment is needed. Then we go to the non-REM parasomnias. We have here confusional arousal, sleepwalking, and night terrors. They occur mostly at stage 3 of sleep. Remember that deep stage of the sleep. It is important to know that these conditions run in families, and they can be precipitated by any condition that reduces sleep duration. They have some common features. They occur within a few hours of sleep onset. So child goes to sleep and the behavior starts. They last for a couple of minutes, and children have the appearance of being awake, but they are actually not awake. They are difficult to awake, and if awoken, they will look confused. The children will not recall the event, okay? And how we treat them is reassurance to the parents, right? And we reassure that these are neurodevelopmental phenomenon that do not indicate any psychological issue or problem, and they do not result in any harm in the psychic or the psychology of the child. We also provide education around safety measures when there is sleepwalking. So if the kid is walking when they are asleep, we need to make sure that there's no stairs around and all these type of things that can place them at danger. There are 2 other big non-REM parasomnias that are discussed. One is the teeth grinding, and the other one is the bedwetting. They are under the same classification. And it's important to know that this, even though there's nothing to worry about in terms of the psychological effects of this presentation, these parasomnias can coexist with other sleep disorders. So it's important, if they happen as the child continues to develop, if any sleep concerns ensue, to bring this information to your doctor, okay? We have the nightmares. Nightmares are universal and part of normal cognitive development, peaking between 6 to 10 years of age. Nightmares are defined as frightening dreams that usually awaken a child or adolescent and often involve a negative emotion. The kids call them the bad dreams, scary dreams. And we know that not sleeping enough, insomnia, anxiety disorders, stress, traumatic events, and some medications might predispose to nightmares. The assessment and diagnosis is clinical. And the take-home point here is, if you have a child with nightmares that persist throughout the development and they are disrupting the child's sleep, they might warrant a mental health evaluation. This is the big one for adolescents, the circadian delayed sleep phase disorder. It has a high prevalence in adolescents, and it also runs in families. So 40% of the adolescents affected have another family, a person in the family with the condition. These are the night owls who have difficulty falling asleep and waking up at socially acceptable times. The assessment and the diagnosis is clinical, and we sometimes include sleep diaries. The treatment for this is behavioral intervention. We go back to those recommendations from the beginning for maintaining the sleep-wake cycle of having regular sleep-wake times, avoidance of bright light before bedtime, natural light exposure in the morning. And we actually like for parents and kids to monitor how they are progressing with their sleep. Medication melatonin here might be considered by a clinician, and that shall be discussed in this melatonin slide. And let's transition to the childhood sleep disorder breathing. This is the obstructive sleep apnea. There are some risk factors that are identified for it, being African American, and some anatomical differences because of underlying medical conditions. We make this diagnosis by history and physical examination, and this one requires the sleep study that we mentioned at the beginning. There are different causes for this sleep apnea, and when big tonsils are the cause, probably the child is going to be referred to an ear, nose, and throat doctor who might recommend removing the tonsils and adenoids. This is on a base-to-base cases and assessment and recommendation. Some kids will need continuous positive airway pressure therapy, and this will be determined by the sleep study. And as obesity has become a public health problem, the changes in the distribution of this specific disease has changed as well. And for the apnea associated to obesity, we recommend diet changes, exercise, and other safe ways to lose weight when obesity is part of that presentation. We transition briefly. One important point here that I don't want to miss. I am so sorry. Okay. If you see the lines at the bottom of the slide, there are symptoms of this presentation at night and during the day. And if we look through that at day, poor school functioning or other behavioral concerns such as inattentiveness, difficulty learning, hyperactivity, impulsivity, irritability, rebelliousness, aggression. Spoiler alert. Can we recall familiarity here from a previous slide? Okay. Let's transition now to restless leg syndrome. This is usually runs in families. There is an urge to move the legs with associated discomfort. It often starts in the evenings, worsens with rest, and eases with movement. May be associated with iron deficiency and is associated with negative behavior, mood changes, and ADHD. Assessment and diagnosis is clinical. Sometimes sleep studies are indicated, and the treatment is usually the avoidance of offending substances such as nicotine, caffeine, and some medications. And some physicians, when they do the studies, they might decide whether iron replacement is warranted. I'm just going to mention this one here, narcolepsy. Actually, clinicians are unfamiliar with narcolepsy symptoms, and this lack of awareness likely contributes to the delay in diagnosis. And although it's a rare cause of excessive daytime sleepiness in children, the more severe the sleepiness, the more we need to think about it. So a child that is falling asleep, that has attacks of sleep, we need to monitor and tell to your physician or medical provider that warrants assessment. There is a specific treatment for it. Sounds familiar. 5 years old with difficult behaviors, was diagnosed with sleep apnea. I'm just gonna put it out there for 5 more seconds so you can see those presenting symptoms and how they relate to sleep apnea, okay? What about melatonin? I'm not going to forget to discuss it. So melatonin is the most commonly used hypnotic drug or a drug that creates sleep. It's well accepted by caregivers. I bet some people in the audience is taking melatonin. It has accessibility, or in our families. It has accessibility of low cost, and it comes in multiple formulations. It's important that you know that we have some evidence for efficacy in typically developing children and those with neurodevelopmental disorders. It has minimal effects on sleep architecture, and it has a low side effect profile, which is good. And the bottom line is this medication is most appropriate use in patients with diagnosed circadian phase delay, and can be a reasonable choice in general special pediatrics populations, such as those children suffering from ADHD and or have autism spectrum disorder with sleep onset insomnia, who may need longer term medication. So all this, doctor, but what can I do to make my child understand the importance of sleep? What can I do? This is not enough. I try everything. First thing I'm going to tell you, mom, dad, grandma, caretaker in the audience, is be kind to yourself. You are doing a great job. And we're going to take all those self-reflections that we did, and we are going to start acknowledging how the familiar and cultural practices can potentially impact the children's sleep practices, okay, with kindness. We are going to start acknowledging, remember that there are some protective factors for sleep that daily, and those include daily bedtime routines, the limit setting, reinforcement of the expectations around sleep are essential elements of the child's sleeping practice. We have to be consistent with those expectations and those limits, okay? Really, really important. We need some flexibility here. We need to acknowledge your child developmental stage and how biology might be contributing to the disrupted sleep patterns. Because as you saw, there are changes, and sometimes we might need to reconsider if we have like strict sleep times when children are approaching adolescence. How can that be modified? Or if the forbidden zone is at the time of sleep for the younger ones, how do I put that into practice? I think the most important thing that we can start doing is starting those conversations around sleep and health with your children and your families. We should help them practice sleep hygiene, and sleep hygiene is basically the recommendations that were given through. It's a set of recommendations that were given through this talk today, and how to put them in practice. Aside from the sleep, we have to promote healthy eating patterns and exercise, sedentarism, pure diet, and limited intake of good nutrients can actually impact sleep. And this is one that is difficult. We need to lead by example. And as a parent, I have to remind myself that if it's late at night and I have my phone and it's time to sleep, they are always watching, right? So this is super important. And I usually recommend to explore active school stressors. What about transitions in the school? Are there deadlines coming and he's unable to sleep? Is there bullying? Because these things are happening, and these are not easier times in terms of development. A lot is happening in the brain, right? How we address this with our healthcare providers. So if you have a concern, if you see a red flag, if you identify some of the things that predispose us to sleep, if there are sleep disorders in the family and you're concerned about your child, bring this to your physician. It's easier if when you come, you have like a list of the routines and patterns of the daily activities and the sleep routine in the weekend versus the week. You can do those observations in a sleep diary, and there are some references at the end that I share with you that you can link, and you can take a look on how it is used. We have to start the conversation around sleep and health with your medical provider. If it's concerning to you, bring it as a main concern. If you feel that something took priority because it was vaccination, and the pediatricians, they're the best physicians. I admire pediatricians, and they have a lot of responsibility. So if it's something that you're concerned, just bring it to their attention, okay? Help your healthcare provider understand your child's unique conditions at the time of sleep and your possibilities and limitations as a parent. Share what's going on in the intimacy of your house, because this is important and might be contributing to the sleep. And be aware of your family history of sleep disorders, and be aware of the medications. When you come to the doctor, carry an updated list, including over-the-counter medications and herbal remedies. And this is my take-home point. I hope we start all sleeping the adequate amount of time and with good quality for a healthy development, okay? Sleep is a dynamic process, that it's important. It affects children, and it can potentially affect their development and their health. And it can manifest as behavioral, attentional, and academic problems in children or youth. If there are sleep problems, be curious and talk with your child, and let the school and their doctor know, okay? I hope everybody tonight starts sleeping for a healthy development. These are the resources. And I really want to appreciate the opportunity of being here. Gracias. I want you all to please stay tuned for the second part of this series with Dr. Ashura Buckley on March 28th, 10 a.m., same channel. This is, I'm part of the research team. I included this here, where there's going to be more information on this in the second part, but I just wanted you to know that we are trying to understand sleep patterns in young children, and Dr. Buckley will talk more about this. And I'm open for questions. Thank you for your time.
All right, Dr. Concepcion Gonzalez, thank you so much. Wow, I learned so much today, and we really appreciate your time with us. So we're going to start on some questions. And please, I encourage everyone to please put your questions in the chat, and we will get to them. All right, our first question is the amount of sleep for children is expressed as a range. How would we discover where a child is within that range? So she has an example. She said, my elementary child sleeps 9 to 9.5 hours a night, but how could I know if he needs 10? Is there a way to discover what his natural circadian rhythm is?
Oh, that's a really, that's a really good question. And that's actually an area of emergence right now in the research world. This is in the infancy of what we know about circadian rhythms, right? And the reason the experts provided these ranges is because we know it's varied, right? So what we recommend, we want them within the range, right? And what we usually observe, it's how they do it and how they recommend to do it. It's to check on when they don't have class, right? Just to make observations around what are the regular patterns of their sleep upon awakening. We encourage to keep their routines because kids get easily distracted, but that's a whole science for the person who asked this question that we are getting to understand right now. But the bottom line here is make sure that we are within the range and that the child does not exhibit any of the red flags. Does that answer the question? And if it doesn't, please let me know.
Okay. All right. Thank you. So another person is asking, can sleeping longer, for example, on the weekends for all ages, help fill the gaps in less sleep during the week?
So there was a recent study at the molecular level that is starting to answer that question. And what we know so far is that we cannot make up for the time that we were not able to sleep. And there is chronic accumulation. When we sleep, what happens is, I don't know if you remember at the beginning, that sleep time is a time for restoration and healing of the central nervous system through a specific system called the lymphatic system. And that needs to work on a nightly basis. And we know when it doesn't happen, it seems from the evidence that we're starting to get that there is accumulation. There is accumulation of those the toxic waste that we're not able to get off, and it can potentially affect sleep. It can potentially affect the brain, actually. So we need to sleep every day. It has to be
Every day.
We never catch up. Yes.
All right, thank you. Is parental presence at bedtime something that is good or something to be reduced?
So we recommend bedtime routines, right? In children, if they are 3 to 12 years of age and they love reading, include some reading at that time. After that time is passed, like every family has their own routine, and I'm going to give a simple one. They have dinner, they had some time to rest, they go up, take a shower, brush your teeth, reading time, right? With set amount of time of expectations. Okay, close the book, night to sleep, everybody. We should be able to separate from the child, and the child should be able to stay in the room. So we recommend that. But that also, remember all those emotional regulation that the child goes depending on the age. The recommendation is try to have a routine. And the best thing is for them to associate the routine with the time that we finish our things. Mama, dada, granddad, guardian says bye. And hopefully they have the tools to self-regulate and be able to sleep by themselves. We understand that some conditions will not allow for kids to have their own bed. But if that's the case, still the routine, it's important. The routine.
Yeah,
and we recommend less time.
No, I completely understand that.
Yeah.
So another parent is asking, just talking about her 4-year-old daughter who cries and screams in her sleep. She said usually 2 to 3 hours after she goes to sleep. And so she said she goes to bed around 8, but around 11 p.m., this is when this may occur. She said, when I try to comfort her, she might kick and push me. Why is this happening? What should I do? She said, sometimes I'm able to wake her with a sip of water, and it seems to calm her down. Sometimes other times she's inconsolable.
Okay, so I don't know. There is the confusional arousals that can look like that. My recommendation is observe how many times a week that is happening. Write it down. Describe how the child looks. Does she remembers what's happening when she wakes up in the morning? Does she remembers? And make a log of those things and bring it for assessment. These things are can be neurophysiological processes of the parasomnias that discuss, but if it's happening consistently and the child is awake for a long time, it's gonna impact them. So it needs the answer is it needs further medical assessment.
Okay, no, makes sense. Absolutely. So that is really kind of all the questions we have from our speaker, from our participants. But I do want to I want to leave the chat open. Any other questions for Dr. Concepcion Zayas? I think you provided us with so much thorough information, and I do have a question about. I know you talked about melatonin, and I would say I was one of those people that was kind of taking melatonin, and then I read some studies, and I'm like, oh, I probably shouldn't be doing this every day. But I know you talked about, and specifically in children. And I guess would it be that we need kind of a discussion with our medical physician to kind of talk about this before we might start maybe a trial of melatonin with a child? What are your recommendations again?
So for starting, I always say everything that we put in our body, including food, right, can have an effect on us in the form of allergies, in the form of any sort of manifestation. The medical recommendation is usually, if there is a concern, address it with your physician, right?
Right.
We know there are parents that there's a long waiting time. They
Mhm.
are unable to get to the doctors, and this child needs to sleep, and they start using it. I think it's important, if the child is already on melatonin, that they also go with the concern
Mhm.
and let the father know, as we let the physician know. As we
Yeah.
saw, we have data on how it can be appropriately used,
Mhm.
but how it's used depends on the manifestations of the sleep disorder of every
Right.
individual. So we want to make sure that we're understanding it well, because since it's a physiological process, right?
Mhm.
We want to make sure that we're using it in a way that that it actually enhances our system, not in a way that can potentially big a
Mhm.
counterfactor to it.
Right. Thank you. So we have a participant asking about sound machines and if they're recommended.
So
Or
this
what are your
is
thoughts? Yeah.
okay. So my thoughts here. So this is what it's called, the white noise,
Yes.
right? The white noise, and it's ah. So I like to say that everything that we recommend, it's based on individual
Mhm.
assessment, right? I
Of
cannot
course.
say it's good or it's bad for your child. Some children, this becomes a nighttime association, right? The noise.
Mm.
So if they don't have the noise, will they be able to fall asleep? So the
Mm.
discussion will be around, oh, the child needs this white noise. Will he always have access to this white noise to fall asleep? Because the answer is no. Then how are we gonna address when we don't have exposure to that? And I don't know, I like the evidence is not solid around it. Some people use it and it helps. And when we are in the clinical setting, right, we sit down and we talk about all the things that work and don't work, and we can make a informed decision together. Uh, but the evidence is weak. Could it help somebody? Personally, as a doctor, I've seen people who use the white noise and it helps.
Yeah. Okay. No, thank you. This is the $1,000,000 question, and we get a lot of questions even here at the Parent Resource Center. When should kids stop using their electronics before bed?
This is when the kids start not wanting to come back to me again.
That's right.
When I have this discussion, it's like, okay, bye, disconnect completely. So we usually say 2 hours before bedtime, assuming bedtime is 8 to 9 p.m. But if we go back to how the circadian rhythm works and how can it be varied, like really, really good first question that we had here today. I usually like to say 6 to 7 p.m. is late. And
Mhm.
I tell the kids, you know what? It's Dr. C's recommendation. Don't blame mom.
Mm.
And I try to make them understand. At least 2 hours is the recommend, like at least 2 hours. And there's a lot of negotiation around that happens,
Yeah.
like with everything. And
Right.
it's the daily. This is a daily conversation with the parents and with the kids. So we need to bring the kids into the discussion
Yeah.
and help them understand why it's something that it's for their developing brains.
Yeah. When I think about, say, like our high school students who might be doing homework and they're using their laptops and it's 9 or 10 o'clock, um, I know that can be a struggle, and I'm sure you've had those conversations.
Yes.
Um, how do we help our older students balance this a little bit because they have homework to do. It's usually oftentimes electronically they're doing this homework. So I think it's helpful to understand how we can support our children, but also maybe even how do we support um, even our teachers kind of helping our students understand these things.
So this is something that I spend a lot of time thinking about, because
Mhm.
I think this is sometimes an unfair request for the
Right.
child, right, and the adolescent. And I think one thing we can do to support the older adolescents is helping them with the daily routines
Mm.
and how they are able to manage the times during the days in order not to do everything
Dang it.
at the last moment, because this is usually what happens. As we discussed developmentally, they have all these social expectations, the group, sports, practice, singing lessons, all these things, and it accumulates, right?
Mm.
But then when they are unable to fall asleep, well, their function starts to diminish.
Right.
So
Right.
what we can better provide, and this is something that I will actually encourage, and I think every child should have access to, not only when they have problems, is to have like a class for how to organize my day and how to prioritize,
Yeah.
for real, because we do
Yes.
it with the
Yes.
kids on the special education setting, right? And
Mhm.
we put 1-to-1, and it's good that they have, but I don't think we do. I think we can do a better job in
Mhm.
terms of providing these skills
Yeah.
to the adolescents. So I
Yeah.
think in the side of the teachers, which this is an unfair request also for the teachers, there's limit time. They're doing like teachers are doing everything. And by the way, take a time to thank every teacher that has taught us everything that we have
Mhm.
and that we know. But it's an unfair request directly to the teacher. So I think it needs to be like a systemic consideration on how to
Mhm.
incorporate these recommendations at a level that everybody has access to it, and we can
Yeah.
actually prepare kids for a
Yeah.
healthy, productive day with good sleep at night.
Right. Right. Wow, I know. And that I will tell you that, that is probably going to be a work in progress. But I totally get it. There are lots of conversations around homework, and what that should look like. And, so there may be some slow things to happen, but I totally hear you. Absolutely, totally hear you on this. Someone did ask about blue light glasses. Um, and I don't know if you can speak to that. Do they help, you know?
So I've read about the blue light.
Mhm.
There are a couple of studies. I've
Mhm.
personally never yet recommend one. There's
Mhm.
emerging evidence on how to use them to protect the screens at night,
Right.
right? I will say they decrease, right, the frequency. And basically it's a frequency that are neurons in the eyes capture. So
Okay.
using them to protect, I think it's important, right? So if you have
Mhm.
access to them and you can use them, that's good. But having the caveat, that doesn't mean that it's protecting you from having your brain active and exposed, right?
Right.
You're still
Exactly.
exposing your brain, and
Brain.
you're still keeping your brain active. So they are protective. They have some studies around them going on. I don't believe they are for children. I believe the ones that I read are for adults.
Mhm.
Um, but I mean, everything that we can use to protect, yes.
Mhm.
Bottom line is we have these processes. There's still exposure, right? There's still
Right.
activation when we
Right.
should be like fading down and putting our stress levels, like our cortisol levels down.
Yes.
How that countermeasures.
Right. Well, thank you. And I will tell you, being a parent myself, modeling good behavior on our end, not being on our screens in the evening, I think also sends great messages to our students. So thank you for reminding all of us about that, because I think that's also really important.
I
All
have to
right.
remind myself every day.
Yes. Right. Right.
Every
Exactly.
day, because we have to
Exactly.
work late sometimes, and it's like, oh my God, I
Right.
cannot do this. So
Right. No, but thank you. It's always a good reminder, and we will do our very best. All right. Well, thank you so much, Dr. Zayas. This has been such great information and so much for us to think about as parents. and guardians and caregivers of our wonderful children. So I want to thank everyone today for joining us, and really appreciate your time with us. And there is an evaluation in the chat, but I also will send that along in the email that I will follow up with everyone. So again, Dr. Zayas, thank you so much for everything today. And we look forward to our next installment with Dr. Buckley, and we'll see you all in 2 weeks.
Two
So thank you.
weeks. 2
Yes.
weeks. Be
So,
here.
all right. Thank you, everyone. Hope you all have a great day.
Bye.